Welcome to this learning module on continuous glucose monitors. I want to start by acknowledging with gratitude that this presentation was created on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh First Nations, and I'd like to thank them for their stewardship of these beautiful lands. So we'll talk today about an overview of what CGM is, some of the good things, some of the not so good things, and the use of CGM with insulin pumps. I also want to talk about time and range and ambulatory glucose profile reports so that you can interpret them a little, the results well. When we look at a continuous glucose monitor, we're seeing the bigger picture. When we test someone's blood glucose with a finger poke, and even if it's 4 times a day, which is quite a lot, we're not seeing what's happening in between the meals or overnight, how the body's reacting to food or activity or medications. And we can set alerts to catch the lows and the highs, look back at trends, show the current glucose value, and a predictive arrow to say what direction the sugars are going and how quickly that glucose is rising or falling. So if you're driving a car, you don't want to look down all the time, and that's what you get when you are testing a finger stick glucose, is you know exactly where you are. You want to be able to know where you are, where you're going, and where you've been, and CGMs give you the 360-degree view. What's very important to remember is that a blood glucose is not the same as interstitial glucose. So you can see here in the blood vessel, those blue dots are the glucose, and when you do a finger stick, you are seeing what the glucose level is in the actual bloodstream, in the capillary. When you have interstitial glucose, those blue dots need a little bit of time to get from the blood vessel into the interstitial fluid, and that's where the sensor is picking up the glucose levels. So if the levels are changing very quickly, it's harder for the glucose to get across those membranes quickly, and sometimes there might be a discrepancy between the blood glucose reading and the interstitial glucose reading. So there is a bit of a lag time that happens. Now that lag time has been improved greatly over the years. It used to be about 10 years ago that lag time was up to 20 minutes, which is not appropriate. You can't dose insulin off of a result that was 20 minutes ago. But now that they have better technology, these lag times are anywhere between 2 and 4 minutes. And if a person is wearing the Medtronic system with their insulin pump, that lag time, although it's not finite, they say it's similar to the Dexcom or the Libre. But we also have to realize blood is always going to get there first. In a race, blood's going to win. So if you're ever concerned, you always go back to a finger poke. If the glucose levels are rising very quickly, as indicated on the train that's going up the hill here, the blood glucose is in the front train and the sensor glucose is in the back train. If it's changing quickly, the sensor glucose could lag behind by up to a couple of millimoles. So it's not that it's not accurate, it's that it just takes a few more minutes for it to reach the blood glucose. So the best time, if you ever want to compare glucose levels, is when the glucose is not rising or falling quickly, when it's in a more stable state. And then here's another pictorial. So if you're still not going to have exact numbers every time, and that's because you're measuring from 2 different compartments. So in the far left of this graph, the blood glucose is in the front of the train, the sensor glucose is in the back of the train, and if it's stable and there's not a lot of fluctuation going on in the glucose levels, as indicated by the arrow that's on these devices, you're going to have a pretty similar reading. But if the glucose levels are going up, blood glucose is going to read higher because it got there first, and that's the direction the sugar is going. The more important one is if the glucose levels are falling, and let's say your sensor glucose reads 4.4, it's already, you know that blood glucose is lower than 4. And so that's when you can actually treat a low glucose before they ever got to 4 by setting the alerts at possibly, when the sensor glucose drops to 4.8, tell me, because I know that it's very close to 4 in my blood glucose. Now, the accuracy has improved greatly over the years. Like I said, the lag times were very long, so it wasn't appropriate, but most point of care meters, including the hospital ones, are allowed to read up to 15% off of the lab, but they really have been settling in at about the 7 to 10% range for the blood glucose meters. Well, now you can see here with the newer versions, the Dexcom G7, the Libre 3 Plus actually, it is their mean absolute relative difference, or MARD, which is their percentage variance off of the lab, or VBG, is actually in the 8% range. So it's rivaling any of our point of care test glucose meters. So what's the good? The person can see their glucose result in real time. They can look down at any point and see what their glucose is doing at that moment. They can also share those results in real time with family or caregiver and healthcare providers or clinics, because it will automatically upload to the cloud continuously. They can take action to prevent the glucose levels that are climbing or falling. If they set alerts and alarms on, they can say, oh my goodness, okay, I ate something that was causing my sugar to go up quickly, so I better go get some insulin. Or maybe I go out for a walk now. Or maybe I drink some water to try to dilute that down a bit and go for a walk. And it can help with seeing the impact of choices on their diet, activity, and stress and hormones and medications. So I actually advise people when they're first wearing them is do a glucose challenge. Go to the buffet, see what your normal choices at the buffet are going to do to your glucose levels. Then you can make adjustments from there. They don't know what it does because they're not continually poking their finger for it. So this is great information for them. It's discreet. Usually it's worn in the back of the arm in the case of the Libre or the Dexcom system, and Dexcom's the only one that, or Dexcom and Medtronic can be worn in the belly as well. It's simple to use. They've now made those insertions and those inserting devices extremely simple, one push of a button, and it provides comprehensive reports not only for the patient, but for the healthcare provider. And it's proven to improve A1C just by wearing it. So it's like having a weigh scale in your house and using it regularly. You keep more accountable. And it's waterproof. It had to be waterproof. You can't take these things off in the middle of their wear time. Some of the drawbacks are that they're costly. So most of the sensors cost $100 a piece, but it depends on how long they will last. So a Dexcom will last for 10 days, so that's $300 a month. A Libre system, the Libre 3 Plus, which is what we're moving towards and away from the 2, is 15 days, so that's $200 a month. And Medtronic is 7 days, and so that means they need 4 of them a month. There's limited coverage, and it depends on whether you have diabetes or not, or partial coverage. And sometimes people don't want to wear something 24/7. And it may provide too much information, and they get into a system or a pattern of over-treating the high glucose results with and a result in stacking their insulin and a rebound hypoglycemia. And it might cause them more stress to have that information. And they have to remove it for certain medical imaging tests, and it's not indicated in certain health conditions like dialysis. Although people with dialysis do wear these devices, they really should only be using it to see what direction the glucose levels are going, and if they need to treat with insulin, they should be following up with a finger poke before they decide on their dose. So this is a general, this is a list out of Providence Healthcare for the devices and when they should be removed, when they need lead apron over top, and when we can safely put them through the test. I will say that there's some emerging data to show that you wouldn't need to wear CGM in MRI or CAT scan anymore. But that data has not been approved by Health Canada just yet, so we need to continue on with this list. And there is a growing body of evidence that supports multiple facets of diabetes benefits for people wearing CGM in both the type 1 and type 2 diabetes sphere. It definitely reduces the A1C because people are monitoring their sugars more closely. It can decrease hypoglycemia because it will give them an alarm or alert if it's turned on. And there's severe lows that you cannot turn off that alarm. So if they go less than 3, then this alarm will go off whether they turn the alarm off on their system or not. It can't be turned off. It's got an increased time in range, and time in range is the time that they are between normal blood sugar limits, between no lower than 4, no higher than 10. So they spend more time in those good glucose level zones. They have decreased hospitalizations because they can act more quickly. They have an improved quality of life and satisfaction because they can self-manage better. And there's decreased absenteeism shown in these studies as well. So helping patients understand how all of the actions that they take just to live with diabetes can impact their glycemic results. A CGM can show them all of that. So they can show them whether they're needing more insulin because their disease is progressing. They can show whether the timing or the quality or quantity of the food or different food group combinations, the glycemic index is going to impact the glycemic outcomes. The activity, so they can see, oh, look at this, when I go for a walk, it actually does reduce my glucose levels. And then they can have more buy-in with their self-care. We're asking them to manage their diabetes 24/7, but weren't really giving them the technology to be able to do that well. And definitely it shows the impact when we start a medication or increase a medication or change it. They can see in real time how it's doing with their glucose levels. So let's look at what you're going to see on the app or the reader. This is a cell phone example of the Libre system. So I'm going to see some trend arrows, and they're going to tell me if the sugars are rising quickly, rising slowly, if they're stable, falling slowly, or falling quickly. And so you can see that trend arrow in here. And then I'm going to see the actual result of the interstitial glucose in here, 6.2. I'm going to see a green label in the background saying glucose is in range because it's in a nice range between 4 and 10. And I'm also going to see this dot here is what the glucose level is now on a graph, and then what the past 8 hours have looked like. So it shows a reflective view of what their glucose levels have been. So that's the rear view mirror. And here's what you would see on the Dexcom system. So you're going to see color coding in the middle, the number of the CGM result, and you're going to see these trend arrows, whether they're angled up and only 1 arrow up or 2 arrows up going very quickly. This is quite normal. 5.3 and a double arrow up means you just ate. Of course it's going to go up quickly. This is the more dangerous one. If the sensor glucose is reading 3.7, remember back to that slide that blood is getting there first and the trend arrow is going down. It means they're already in the low 3s from this. And here are some examples of the commonly seen ones that you will see most often. If they're using the Medtronic one, it's usually with the insulin pump, and that's more rare. So the Dexcom G6 is actually being phased out, but it still will be around for a few years. But the G7 is what we're looking at, and that is the sensor and the sensor and transmitter are all in one piece, whereas the G6, the transmitter is actually removable. They have real-time alarms, real-time alerts, and real-time following for family members or trusted caregivers. And then the Libre, Freestyle Libre 3 Plus actually is a 15-day wear time, and that is a very small, it's almost the size of 2 pennies, if you remember what a penny is. They're the smallest available CGM on the market. Now I want to talk about time in range. So I mentioned before, time in range is this green area that's anywhere between no lower than 4 and no higher than 10. So that's the range that we want them to fall within. But there are acceptable targets for this. We don't expect people with diabetes to have perfect blood sugars. They have diabetes. They're probably not going to have perfect blood sugars. But in the older or high risk type 1 and type 2 diabetes population, we expect a little bit less in terms of time in range. So typically for anyone without risks, an older adult, we would say we want 70% of the time for them to be no lower than 4, no higher than 10. We allow them a little bit in the higher range, so you can see here that, you know, between 10 and 13 or 13.9, no more than 25% of their time in that, as well as in greater than 14, no more than 5%. But in our older and high-risk adult, we flex these targets a bit, and you'll notice that doesn't add up to 100%. So there's some averages in there. We want, you know, at least 50% possibly time in range. And we really want no low blood sugars in any population, but definitely in our older and high-risk population. And then you can see the estimated time in range recommendations for pregnancy and type 1 diabetes, and pregnancy and gestational and type 2 diabetes over here. So what do they actually mean when we say 70%? What does that mean? Well, it means that if you're spending 70% of your time in no lower than 4, no higher than 10, that's about 17 hours of the day. And we want more time in that green range. We don't want much time in their low range or very low range, and we don't want much time in the high range, but we, of course, we know that those targets or those instances will happen. And then here, if you're 50% in time and range, you're spending about 12 hours of your day. This is what we used to get years ago. So it's a dog's breakfast, and it's if your color printer was on the fritz, you were out of luck if you were trying to analyze these. So it is just to show how improved things have happened, have become, in that now we are being able to look at this graph in a much nicer format, which I'll show you. So here's this graph again over here, and it's called an ambulatory glucose profile. So we get all this information on this report. This one is for the Libre system, and we can choose reports, we can drill into them deeper, we can find different reports and take a look at them there. So we can see what's going on with their average glucose, how often they're wearing it, their wear time, how much their A1C is estimated. So if they're wearing this for, if you've got more than a few weeks data, you can get a fairly general idea of what their A1C might come back at the next lab value. If they've had dramatic lifestyle changes and it's only 2 weeks worth of data, it takes 3 months for that result to really adjust. So it may show beautiful results in this AGP graph in the middle, but it's not reflected in their A1C yet because they just need a little more time in that beautiful range. But what you can see here is that we're looking for a tight, narrow river, essentially. So this is the average glucose level at that time of day over the past, how long is this? This is 1 month's worth, or 14 days worth. So over the past 2 weeks at noon, there've been quite a bit of variation. We want a tight river, which would be here. Although that's drifting in the low range, that's a lot easier to try to adjust the insulin on than something that's this varied. One day they're 20, the next day they're 3, the next day they're 14. This is more challenging to manage than someone who has either low or high glucoses, but they're in a tight range. So the glucose statistics and targets are available on here, the time in range, the ambulatory glucose profile, and the daily glucose graphs. We can drill in and say, oh, what happened on Tuesday here? Things went really high. So it gives us much more information. And AGP, I mentioned, we just want this tight, narrow river, and it's a few steps that we want to look at. First off, hypoglycemia. We're always looking to see if there's any hypos. And in here we can see that, yes, there is a bit of a pattern of hypoglycemia, and this median line of the average glucose is starting to drift down quite low in this time of day. So we'd address, if this is at, I think that says 6 o'clock in the morning, we'd address what insulin we gave them the night before, because maybe things are going, they have too much insulin on board there. Then we'd say, okay, what's going on here? What are you eating? What's your activity? Are you taking your medication? In this wide variation here, and try and get things to be a little bit more consistent with them. So are the readings within target range? We're essentially looking at this dark blue shaded area in here, and these light blue ones are the outliers. So you know, majority of them are falling between, in this case here, this would be between about 5 and 14 in this area here. But then we've got a couple of outliers. So one day you popped up to 20 and one day you popped down to 3.2. So those, the lighter out shading ones, we don't worry about as much. It's this darker shading area. And what's the shape of the median curve? The average glucose is this line here. Well, we want more of a flat river, consistent. We don't want spikes up. We see that we're having spikes down. So we'd look at that median curve. And then the interquartile range, which is the inner 25 to 75% ranges that are most concentrated here. And that's what we're going to look at to make changes on. So glycemic variability is a fluctuation between high and low readings. It can occur during the same day or between days, so you have a good day and not so good day. And it's linked to diabetes-related complications. So it's linked to severe hypoglycemia because you don't know one day to the next whether you're going to have a high or a low. It's linked to cardiovascular events that are associated with glycemic variability. As the fasting glycemic variability increases, so does the risk of severe hypoglycemia. MACE and all-cause mortality, which are all cardiovascular measurements of mortality. And there is more damage to the inside lining of the blood vessels short-term than if the glucose levels remain high. So we're better off actually leaving somebody consistently high and bringing them down slowly than we are having this variability between days. So how do you know when or if to intervene? So if someone has got an A1C of 7.2, and this person I think is 7.3 in here, I'd take a look at that and go, well, that's not a narrow river. There's a lot of more high sugars than anything, and that blue line in the middle, the median line, is a little too squiggly for me. So yes, I would intervene on that. But if someone had really consistent glucose levels and they were A1C of 7.3, we may not want to intervene. So when we assess glycemic variability, I want you to take a look at some of these AGP graphs and tell me what might match. So have a think about this. So if the average glucose is 9.7 millimoles, and they're estimating an A1C of about 7.5% based on their past patterns, and their glucose variability, which should be less than 36%, is 51%, that would mean there's a lot of variation. So this means that, of course, this is not going to apply because the average blood sugar is not 9 in here, or 9.7, almost 10. This one wouldn't apply because the glycemic variability is not that bad. And this one is the one that you would take a look at and say, I think that the glycemic variability is higher on this graph. So that would match what this report is showing. And then the, okay, we got that. So when we apply this to practice, we record all the patient's readings at a time on a 24-hour visual map, essentially. And we've got a nice tight river in the top one, and we've got a lot of variation in the bottom one. So it reveals trends and variabilities, aiming for the flat narrow, and finding a way to visualize variability very quickly. It is much easier to look at this graph and say, okay, I know this one is a problem and I know this one's okay, than to sit there and go through their blood sugar log and try to, at this one time of day that they're taking the glucose level, try to decide whether things are going okay. It just reduces the noise. And then I want you to think about matching these AGP profiles. So for someone who has an A1C of 8.2% on oral agents, take a look at these and see what might be a match. And just take a moment there. And so here we've got someone on oral agents. It's 8.2%, which is an average of about 10 millimoles. And we've got a nice consistent line here. This would be very easy. We could just bump up the oral agents and bring the entire thing down. If they have too much basal insulin at night, that means that they're having low blood sugars in the morning. And so that's going to lead you to choose which one. And so you're right, number 3 would be here because we've got this severe dip overnight, too much basal insulin, rebound hyperglycemia. So we're going to address the basal insulin on that. If they're not consistently eating mid to late day, then there's going to be some variability, right? So that's going to lead you to you're going to choose number 2 because here's that variability that's going on later in the day. If they're taking multiple daily injections, is it 4 or 5? Let's see. So it's going to be 5 because they're actually managed really well. So the MDI is keeping their sugar in that normal range. And the 5th one would be possible need for mealtime insulin. Look, we've got some rises with each meal. So that is what's going to match over here. So don't settle when it comes to patient safety. This is effective MDI therapy with this AGP and this nice big lot of green in the time and range. This is not effective multiple daily injection therapy. This is a wide variation, not much in the green, and that's how you can interpret these results. So the key learning points are that CGM data can help supplement the diabetes information from the patient and other sources. It can help us drill down better, and we can see what's going on at all times of day without them having to poke. It can allow for many interventions that can improve the overall care of the person with diabetes, so we can make more informed decisions. And these interventions could include better glycemic control and improved overall safety for them. Sometimes we were flying blind. And then if it's used to its full potential, CGM technology can empower the patient and improve outcomes in people with diabetes. Thank you for your time.